we're just talking about it. It's not good. So, okay, can we improve that? Because there are the patients that should be immobilized. So, although we're saying that yes, it increases ICP and people get pressure sores and they get unneeded imaging, we still need to immobilize some of these patients. And so if we're going to, we should be doing that better, because then if you use vacuum mattresses, people don't get the pressure sores and you don't have the increase in ICP the same way. So now you've reduced the risks. Well, I mean, we're not going to immobilize as many people anyway, but maybe we can take sort of both sides of that and say, if we're going to, let's do it properly.
Why is it that the province of Quebec on every single ambulance has a full-length vacuum?
Exactly.
Sorry. Go ahead, Keegan.
And I think this is an issue, it's a systemic issue within paramedicine, is that it's very hard to go out there and take a risk on something, right? Because immobilization seems to work. Why do we like changing it so anti-immobilization? If something bad happens, that's going to just house cars, everything's going to fall down. Now these other areas have done work to show that there's techniques out there. Why does Ontario not want to adopt those to attempt them? Is there a fear about changing?
I'm sorry.
Yeah, and well, that's the thing too, right? This cost-benefit analysis was brought up, and the goods and bads to it. At the end of the day, that's what's going to drive change if people are willing to spend more money. And again, I'm not really sure about how the funding model would work, but there are some services out there that can probably afford to give this a go and try it out, where other services couldn't. So, do we start running trials in Ontario now so we can go, no, it worked?
And the most difficult part with most of these trials is, how would you ever prove that the injury that was caused at the moment of the trauma, as opposed to the injury was then perpetuated or made worse by the treatment, unless you can get a x-ray while they're sitting in their car. I mean, we can talk about mechanisms of injury and stuff like that, which I think a lot of people are a good judge of. But if they were already a paraplegic while they were sitting in the car, can you really say that the extrication made them a paraplegic, or did it happen at the initial trauma? And are we causing more trauma? I think we all at this table believe that by our practice, we're limiting more trauma, or we're preventing more trauma. But are we? And that's the question that I don't think we could ever prove. But that's me. Any other points?
Can I wrap up?
Yeah, please.
Okay, so I figured it'd take 5 minutes just to wrap up, and then we can, what do you call it? After game or something? Overtime.
Overtime!
After
Spoken
game.
like a definite sports fan. After game?
I paid for my ticket and I got
the word
overtime.
I only associate with work now, so I think I repressed that word into the back of my brain.
If we don't sell anything during overtime, we're going to the shoot-off.
Okay. So I actually, believe it or not, there was method to my madness. I quite purposefully put some bias into my presentation because when we were at the SMAC conference, I remember going into this debate. It was Karim Brohi, and I can't frickin' remember who the other person was. I apologize if you're listening. That's awful. Probably not. But
Yeah, the
can you
internet
imagine?
failed 5 minutes ago.
Yeah. That, like the page, if you're listening, that'd be amazing. I went into so it was on cervical collars only, okay? So they have already moved past using backboards to immobilize patients, right? And this was strictly on the use of cervical collars. And I remember going in like, man, cervical collars are the worst. And I can't wait to listen to this debate. And this world-renowned trauma physician is just gonna get put to shame, and he's gonna have no argument. And I can't speak for Colin, but I'm pretty sure that a lot of people there came in with this like Minlacom, throw the cervical collars in the trash can type of attitude. And after I sat there and I was like, fuck, I really, this debate has really changed my perspective on the use of cervical collars, not on immobilization with a backboard. I still do not feel that there is that my personal opinions based on everything that I've read, that, and same thing with the evidence, that's why it's going this way, right, with the Ontario standards, is that backboards and spinal cord and scoop stretchers, etc., are immobilization, or is a very potentially life-altering decision-making process for us, right? And I very, very quickly changed my thought process on the application of a collar, and specifically in the elderly populations. And I have like a very similar anecdotal story to Lisa's, although this guy didn't end up with any deficits because we applied a collar. Or maybe not, I'm not too sure. But I feel like the standard that we have right now, aside from the penetrating trauma part, and we can talk about that, is a pretty safe pathway for you to follow. And I think it really does isolate that. It will remove that 1% that we talk about, right? It catches that 99%. And I like the arguments of Scott was saying about the millions of dollars for that one person, right? Versus the 10, 15, 20, 30, $40 for a collar, a soft collar, or whatever for that patient who we decide that we're not going to put a collar on, that we're saving. But in the end, I think it's just about don't let your biases play in, right? There's research behind it, and there's all kinds of, these guidelines are in place.
Their practice with limiting.
With that decision-making tree, when you're sitting there like, do I put a collar on this person or not, right? Because this is not put a collar on and backboard this person anymore. It's get a collar on them and get them onto a soft mattress, right? So remember that when you start implementing this new spinal motion restriction standard into your practice, that collar doesn't equal backboard, right? So a collar, yes, there is risk of airway and ICP and all this stuff, but sitting a patient up reduces aspiration, it reduces that ICP, right? And you still have that ability to use your good critical thinking and judgment if it becomes more agitated and this collar is causing more harm than good. Or like, I don't know, there's a million different examples that you can think of, but I was really hoping that we would kind of have all the people on this side of the room being like, oh fuck, I got the for mobilization, this is going to be so hard. And it was really nice to see some good debate and really good points that came out of it, because I think it really just changes everybody's mindset to think, yeah, you know what, maybe it's not so hard to put a collar on somebody, sit them up on our stretcher and transport them, because there is that chance that I could significantly impact this person's life. However, having said that, the research is there that shows that there is a big financial cost to doing it, and that spinal mobilization on